Welcome to the NeoFOCUS-UK Education Group webinar series.
Okay, I can see there's quite a lot of people that have already logged in, and I'm conscious that we've got a great talk ahead of us. So I'm going to quickly introduce Dr. Gabriel Altit, who's come to us, who's earned his degree from McGill University for completing his residency in paediatrics and subspecialty training in neonatology in Montreal. He's then returned to McGill University to complete advanced training in echocardiography, as well as completing a master's in epidemiology at McGill's as well. Needless to say, he's contributed so much in this field, and the NeoCardio Lab app looking into TNE and also congenital heart lesions is a must. And I was sort of saying to Gabriel that how I've used it clinically to help me make clinical decisions, as well as many other sort of accolades, as well as creating one of the first Royal College accredited programs of advanced hemodynamics in Quebec. He's an associate professor now at the Department of Pediatrics at McGill University. And I'm going to pass the floor over to him, as I'm sure we're in for a great talk today about phenotyping and acute pulmonary hypertension in prematurity. Thanks very much.
Thank you so much, Liam, and thanks to the committee of NeoFOCUS-UK for inviting me. It's really a pleasure and honor to be here among you. I follow very much so the work being done by this community, and always impressed by how much education and initiatives are being brought forth to our overall community, thanks to all the hard work that you guys are doing. And so it's really a pleasure to be able to kind of share my thoughts on this topic today, and hopefully interact and discuss this a bit controversial topic altogether towards the end. So I hope you're able to see my slide. I'll be discussing a bit the phenotype of acute pulmonary hypertension in prematurity. We'll spend about 45 minutes discussing this, and then we'll be open for questions and discussion. So these are my disclaimers. I do want to mention that it is a topic, there's not a great amount of trials that have been done on this particular topic, if any. So a lot of it, of this content is based from my own experience, but also interpretation of the literature. And I want to put this disclaimer up front. And a lot of the therapies, medications, approaches have really not been tested in the context of RCT. There's obviously been a lot of observational studies coming out from various centers on the topic, but not great trials. And hopefully the community will work together to design some of these trials so we have better answers for our vulnerable babies. And I do want to mention that Mallinckrodt supported with an unrestricted educational grant the website NeoCardio Lab for the year of 2025. So the objectives of this presentation is that I hope that at the end of this presentation, we'll be able to have a better, clearer definition of what acute pulmonary hypertension means in the context of prematurity. We'll go through some of what I call phenotypes corresponding to what sometimes is tagged as acute pulmonary hypertension at the bedside in premature infants. And we'll try to go over some of the literature and some of the physiological concepts related to the management of some of these very precarious babies that we see in the NICU. But I think it's important to go back to basics. I try to do this myself when I tackle complex situations at the bedside. And I always try to step back and say, okay, well, what are the steps I need to go through? What are the systematic understanding of the physiology? And then what's happening in the literature to help me guide the management to really provide the best care to my baby? And then how is my baby responding to that? And do I need to go back to the drawing board? And I want to bring your attention to, I think, this textbook and this work that has been instrumental to the overall field of neonatal cardiovascular sciences, which is the work by Dr. Abraham Rudolph, looking at, fetal physiology. And, we know that in fetal life, our lungs are very much compressed and the pulmonary vascular resistances are very high. We also know that the systemic vascular resistance are typically very low because our systemic compartment is connected to the placenta. And we know that the ventricles are being exposed to this combined vascular resistances because the duct is wide open. And I think for me, it's a very important concept to just keep in mind throughout the talk, because our babies are basically being born at an ongoing fetal stage of different developmental status and different maturity level. Of course, a lot of this work has been done from LAMS, and we assume that this is true in the human fetus. But the concepts of the hemodynamics of the fetus are pretty universal in the sense that once you have the duct that's wide open, you're basically connecting your two compartments, so your pulmonary compartment and your systemic compartment. And I want to bring your attention that, as you can see, the actual pressure that are being generated, which are here 70 on 45 mean 55, which is in the pulmonary artery, are the same pressures in the systemic compartment or the aorta. And it's really the vascular resistances that actually drive the flow directionality. So it's the direction between, it's the PVR to SVR status that will actually provide the flow directionality. And that is true as well in postnatal life, in the sense that when the duct is wide open, it's the PVR SVR relationship that will inform you on the directionality during the cardiac cycle will provide you information on the PVR SVR relationship at that time in the cardiac cycle. So that's an important concept to keep in mind. And obviously, as you can see, the ventricles have the same systolic pressures because they're being exposed in systole to these outflow tracts. And so basically the ventricles are being exposed to these combined vascular territory resistances. And so I think it's important to keep this when we assess patients with what we call pulmonary hypertension. Now in fetal life, we also have the foraminal valley, which is usually wide open. And as you know, because there's very limited amount of pulmonary blood flow, there's limited preload to the left atrium coming from the pulmonary vasculature. And there's a lot of preload coming from both the placenta, the inferior and superior body into the right atrium. And you can see that there's a right to left shunting filling the left atrium in order to fill your left ventricle and provide preload to the left ventricle. And so the magnitude of these shunts will be dependent on what's happening on the RA versus LA side and what's happening on the pulmonary artery and aorta side. And that will be true as well in the postnatal life. Now, the minute you start changing that equilibrium, you may impact the magnitude of these shunts. So I'll give you just an example. If you have a situation of a mother or pregnancy that is complicated by preeclampsia or significant placental dysfunction leading to high vascular stiffness, this vascular stiffness will be reflected on the systemic vascular compartment, which will increase your SVR. And because you increase the SVR, what happens, you decrease the magnitude of the right to left shunting at the ductal level, which will force more flow into the pulmonary vasculature. This pulmonary vasculature will be seeing more blood flow, which may increase the remodeling of these pulmonary vasculature towards an increase in smooth muscle cell just by reactivity. This pulmonary blood flow that is increased will increase the LA preload, which may even further decrease the amount of right to left shunting magnitude at the atrial level, forcing blood flow into the right ventricle, which creates a bit of this vicious cycle of there's more blood flow going to the right ventricle, more blood flow going to the lungs, et cetera, accelerating the pulmonary vascular anomalies that we see sometimes in fetuses that are growth restricted. And so we know these patients are at risk of both developing early onset acute pulmonary hypertension because of some of these mechanisms, as well as to the fact that they are at risk of increased systemic vascular stiffness due to this ongoing exposure to high SVR from the fetal onset. To add more to this fascinating physiology, we know that the placenta provides preferentially more oxygenated blood towards the right atrium and eventually shunting into the LA. And so as you're decreasing the magnitude of this shunt in fetal life, you force more oxygenated blood flow into the right ventricle, which increases the oxygenation content into the pulmonary blood flow, which may also act by decreasing your pulmonary vascular resistance and increasing more the pulmonary blood flow. So there's like a nice vicious cycle that starts setting up in some of these contexts. And you can always go back to fetal life to understand how some of these pregnancy-related conditions, whether it is on the maternal side, fetal side, or placental side, may actually impact both your systemic vascular compartment and your pulmonary vascular compartment, and how can this eventually dictate some of the phenotypes we see in fetal life, especially when some of these babies are being born preterm and some of these mechanisms are very immature. So I've spent a lot of time on these fetal concepts. We're going to try to go now with the afterbirth. So you're all very much expert at the fetal transition. This is a beautiful graph from Dr. Satyan that I'll keep on repeating throughout the presentation. But basically, after birth, we know that these patients are becoming disconnected from their placental side. The SVR will rise very quickly. The lungs are being expanded quite abruptly, and there's both a mechanical stretch happening on the pulmonary vasculature, as well as exposure to oxygen and the release of many biomarkers that are leading to a rapid drop in pulmonary vascular resistances. And so this has been nicely described, obviously, in fetal lamb and assumed to be true in the term newborn. But we actually know that many of these changes are dependent on a fine orchestration of both release of different biomarkers from the fetal side, the placental side, and all of these things are quite affected by the fact that some of our babies are being born at the intersection between the canalicular stage and the saccular stage from the lung perspective. And you can imagine how these lungs are, first of all, very immature, but how all these vascular bundles that are nested within these lungs are also very immature, not just from a structural level, but also from a cellular level, both at the surface of the cell and the intracellular mechanistic level. So we also know that our preterm babies probably have a reserve of endogenous stress hormone, both cortisol level, epinephrine, norepinephrine, and all the fleet of different biomarkers that are being released in the onset of delivery and after that to trigger these different changes that we see immediately after birth. And so you can imagine that if this reserve is very limited, the potential to augment the response in the nest of stress might be very difficult for some of these preterm babies, just because they don't have any more steroid hormone to be released, or some of these receptors have been saturated, or even the intracellular mechanisms have been saturated. And so what we assume to be true for the normal baby, it's even more so difficult to understand what's happening in some of our preterms. And we know that just being exposed to oxygen makes them, at a higher risk of being exposed to reactive oxygen inflammatory changes, which also can trigger issues with some of these babies. So when I go back to the definition of acute pulmonary hypertension, I always think about, for me, this is probably a process of a normal transition. Then some people are going to ask me, well, what is really normal in a baby that's born at 22, 23, 24 weeks, right? I think we need to go back to our physiology and try to understand what are the things affecting these babies as a whole. But what I feel is one of the main mechanisms of most of the cases we see in what we call acute pulmonary hypertension is really a disturbance of this natural drop in pulmonary vascular resistance that eventually leads to clinical manifestation of hypoxia, ischemia, or poor oxygen delivery, poor tissue perfusion, and eventually tissue ischemia and necrosis and even mortality. And so while some of these patients may have still high PVR, and may not have clinical manifestation, there are others that will manifest with different phenotypes because of this disturbed transition. Now, when going back to the bedside, you can see that there's not just the whole process that could be affected by fetal onset of disease, such as in IUGR, but other things like vein of Galen, hepatic liver malformation, like arteriovenous malformation. But there's other disturbers like choreo, like genetic, susceptibility, sepsis, maternal conditions that are, leading to fetal distress, even, asphyxiated setups that can definitely disturb this natural transition on top of being nested in prematurity. And then there's things that happen in the postnatal context that can also aggravate this transition, such as, being exposed to hypothermia, having ongoing uncontrolled infection and the burden and inflammation that comes with it, the lung disease that obviously some of these premature infants will face, and then some of the stressors that will, be implementing because, we're doing care to these babies. And as good as we are, some of these patients may have pain, some of these patients may have seizures secondary to, brain conditions such as severe IVH. And then some of the medications we sometimes introduce may also influence the PVR-SVR relationship. So think about dopamine that sometimes is introduced for various reasons, or other cardiovascular medications that can definitely increase PVR. And then we have sometimes exposure to medications like NSAIDs or endo-ibuprofen, which can definitely increase both your PVR, SVR from a very, prolonged state. And that can also, really change the balance of things and equilibrium that is very tight in these patients. So when we look at the definition of acute pulmonary hypertension, hypertension means, hyperintention. So I do think this is a bit of a misnomer, because hyper means high and tension means blood pressure. And, I'm not sure that this wording truly reflect what we mean at the bedside for many of these patients. And that's what we're going to try to deconstruct today, is say, what is my phenotype and how am I going to try to address this? So pressure, especially in the context of the lung, we have a systolic pulmonary arterial pressure, and we have a diastolic pulmonary arterial pressure, and we have a mean pulmonary arterial pressure. And all of these components will be dependent on whatever stage you are in your cardiac cycle, on the flow and the resistance at that time, and will be dependent also on what's happening in the distal atrial pressure, which is the draining pressure. And then typically this is quote unquote the left atrial pressure, but it's not completely true, because it's really what we mean about the pulmonary venous pressure. Because if you have, for example, pulmonary venous occlusive disease or pulmonary vein stenosis, well, your venous pressure is going to be very high in your pulmonary veins, but your LV pressure might be very low. So it's really the distal draining pressure that we mean by that. And that's very important to keep in mind when we're looking at what we call hypertension. So hypertension to me means that the pressure in the pulmonary vascular compartment is abnormal for age, or abnormal for whatever physiological status this baby should be at. And so I've tried to deconstruct here. I'm going to bring you through all these phenotypes, and we're going to look at different examples after that. You can have a high abnormal pressure in systole or diastole, or the average of it, which is called the mean, if you have too much resistance. And I think most of the time that's what we mean by acute pulmonary hypertension, is that these PVR are too high and are creating a disturbed clinical status for these patients and are leading to end organ injury. So you have often high resistance with what we mean about, the severe PPHN phenotype, or these PVR that have not dropped yet and that are way too high for the clinical status. And that could happen with a closed or closing duct. That's important to make that different scenario. You could have suprasystemic pressure or very high pressure, because you have both a component of high flow and high resistance. So for example, situation where in fetal life, they have torrential blood flow to their pulmonary vasculature, which has created a setup of pulmonary vascular remodeling. And this flow lesion is still present. And so your pressure will rise because of that. And the way I'm going to treat this patient is very different, or will have a lot of nuances in this patient. Then you can have a situation where your draining pressures are a problem. So you don't have problems with flow, you don't have problem with the actual resistance, or actually a resistance might be reactively trying to constrict to prevent, having too much distal venous pressure. So things like left atrial hypertension because of various reasons, like for example, infant of diabetic mother who has severe LV hypertrophy. If you have severe LV dysfunction and your LA is facing high end diastolic pressure, if you have total anomalous pulmonary venous return that is severely obstructed, or if you have pulmonary veno-occlusive disease or vein stenosis, that sometimes we'll see that phenotype happening in some of our BPD patients. So that's much later in the chronic phase, but you can have acute pulmonary hypertension with patients who have diseased pulmonary veins. That's very rare It's called pulmonary venous occlusive disease, and could happen in the context of, a baby that's born preterm, although that's very rare and unrelated to prematurity. Then we have situations where you have too much flow. And so when you increase the flow, by definition, you might react your resistance to decrease the QPQS, but really the rise in pressure unrelated to like fixed resistance or high abnormal resistance. So think about a situation where you're flooding your pulmonary vasculature because of a large left to right duct or a massive VSD that is leading to this pressure and flow transmission. And so in this patient, of course, I'm not going to give pulmonary vasodilators. I'm actually going to try to temper the shunting by doing different strategy to decrease my QPQS, but that by definition will rise my pressure. And then you'll have situation where your RV is starting to have issues because it's not able to cope with the increased resistance. So think of situation where you do have PPHN and your duct is closing. And so at this point, the RV will not be able to increase pulmonary, the RV output. Your resistance will be very high, and the pressure you'll read will not look that bad, but actually your RV is failing. So that's obviously a bad situation. And the extreme of this is what we call functional pulmonary valve atresia, which is basically a dead RV that is just not able to generate any flow. The pulmonary valve is not opening. You have torrential right to left shunt at your atrial level because your resistance is so high that your RV is just like a potato. And your baby's going to be very blue because all your LE preload is from right to left shunting. And obviously these patients can be very sick. And if you actually look at your echo, it's going to look like infrasystemic PA pressure from a TR perspective, for example, just because the RV is not even equalizing pressure with the pulmonary artery because the pulmonary valve is not even opening. So that's actually the worst case scenario for me. And you can see here that this patient would not be in hypertension because there's just no flow in the pulmonary arteries. So there's pretty much no pressure being generated. We often see that in patients with like Epstein anomaly that are very severe and can have this circular circle of death physiology. And so these patients are obviously the one that you want to rescue the most, and you want to avoid getting to that point. The other thing I want to remind ourselves is that some of the therapies that we do for preterm infants will impact PVR for sure. So babies who have these lungs that are super collapsed with vascular bundles that are being squished through atelectasis will have very high PVR just by mechanical compression and poor oxygen exposure. And so the PVR will be very high. And of course, if you're just cranking up the mean airway pressure to a very high level, like high 5 with a mean of 28, well, no matter what, the alveolar pressure will be so high that it will be squishing the vascular bundles, both the arteries, the veins, the capillaries, the lymphatics. And so these patients may have very high PVR just because you're trying to push so much mean airway pressure at the alveolar level. So, we are, as neonatologists at the bedside, trying to achieve this kind of nice equilibrium where our ventilation perfusion matching is good and you're not overdoing by overinflating or underdoing by creating a situation of atelectasis. We also face, extra pulmonary vascular elements that will eventually impact your pulmonary output and increase your PVR. So think about situation like hypoxia, hypercarbia, hypothermia, hematocrit level, acidosis, some of these alpha adrenergic stimulators that we're doing, like pain and seizures. And so all these things have to be kept in mind when we address these patients at bedside and the phenotype that we will look into. So I think we went back to the whole hypertension being like a bit of a difficult misnomer because we have situation where the pressure are actually not so bad on our echo reads, or even if you put a cath, but actually there's very, very high resistances. And the minute you throw also a duct, which will offload the RV afterload, it even more so gets a bit complicated. So we'll go see this is the phenotype. But what I think is important to remind ourselves at the bedside is that we need to better understand what's the cause, what's the phenotype, and then we can tailor the treatment. And it's a bit like if you have a patient coming into the emergency room with a systemic hypertension crisis. Well, of course, the patient who has, Cushing syndrome, or is being exposed to like very high dose steroids for a cancer, or has a renal mass that is compressing the aorta, is not going to be treated the same way, than the adolescent that took a line of cocaine in the bathroom before coming in to the emergency room, or a patient with systemic hypertension for other reasons. So I think we need to go back to the drawing board and do the exact same thing when you see these premature infants who have these hypoxic rest failure and are thought to be secondary to acute pulmonary hypertension, and actually try to decipher, well, what is exactly happening with my patient and how am I going to tackle this? So key physiological concept to be reminded, we just mentioned, you can have high PVR with flow being maintained, with flow being reduced, or with flow being almost non-existent. And that will eventually also impact the pressures that are being sensed into the pulmonary artery, but still, you still have high PVR. And so if that's the phenotype that you feel is going to be a problem, that's probably the phenotype you're going to want to address. The second concept we're going to remind ourselves, and we spoke on the first slide with the fetal physiology, is that the beauty of what we see in neonatology is that there are these shunts that are increasing the complexity of some of the phenotypes that we'll address, but also allow us to create some therapeutic windows. And so when you have two compartments, and that's basically the Boyle law that we learned, back in high school, P1 V1 equal P2 V2. When you have a ductus, so think about the aorta being a box, think about the PA being a box, and you have a huge duct. By definition, you'll get pressure equalization. And that's true always. And so if this duct starts to become smaller and restrictive and it's not able to equalize pressure, that's when the duct gives you a window on like the pressure differences. But when the duct is wide open, the directionality informs you more on the SVR-PVR relationship. Number two, what's true to the newborn, and probably even more so in the context of prematurity, is that RV is very sensitive to afterload. So what is afterload? What I tell always my fellow, afterload is me going to the gym. I take a little bar. I try to bench press. I have no issue. If I start adding pounds, I'm going to start having issues. And if there's like 300 pounds on both sides, I'm not going to be able to press the bar. And so, resistance is obviously related to the RV afterload. But when you have a duct that's wide open, your RV will be facing the combined afterload. And in that sense, it's still sometimes able to cope with that afterload because you're able to offload some of this vascular resistance into the aorta, and your RV is basically facing combined aortic pulmonary afterload. And so sometimes that might be a therapeutic window for some of the premature or at least term infants that we see, is to modulate the duct. So that's just the graphic representation that as you increase afterload, you see that, your contractility will be influenced by that. So newborn will obviously have more issues with contractility as you increase the afterload to the ventricles. And then this is even more true from an, RV component than LV component, where the RV is just not well or is ill-equipped to face increasing afterload and will fail more easily. The other thing that I want to remind ourselves, and that's really the Boyle's law in action, is that we'll often make decision on some echo views, but we'll see that one individual echo view may not provide you with all the information. So this is an example of a patient with a bit of a flattening of the septum and systole. In systole, the outflow tracts are open, and typically your RV will equalize with your PA and LV will equalize with your aorta. And so this systolic motion informs you a bit on both the RV to LV pressure relationship, but really what you're trying to understand is how this reflects your aorta to PA relationship. And so, for example, if you have a wide open duct that will pressure equalize, you will have some degree of flattening of your septum, but that duct could be completely left or right. So it's for us to then better understand what's happening distally in some of these patients and what this informs you on. So you could also have some degree of pulmonary valve stenosis that will increase RV systolic pressure to a near systemic level and have really normal pulmonary vascular resistances and very normal pulmonary, pressure. And again, it's for us to do a comprehensive evaluation by cardiology or eventually by neonatology to better guide therapy in these patients. And then once the duct becomes restrictive, then you have to start thinking, are there other causes? Is it that my systolic pulmonary arterial pressure is rising? Is it that my aortic systolic pressure is dropping? Is it a combination of both? So you can think of situations like sepsis that may influence both, or situations like, Graves' syndromes or, adrenal insufficiency. So that's just an example of a patient with prematurity who had a very large duct. The duct was left to right. The QPQS was expected to be quite high, actually. The LV was a bit dilated. The LA was definitely dilated. And when you measure the pressure, we had isosystemic pressure, and you can see that nice flattening of the septum. That's definitely not a patient I want to treat with pulmonary vasodilator. But that's a patient I actually want to keep an eye on. And eventually, this patient closed spontaneously the duct, and all the metrics of pulmonary blood flow and pulmonary vascular kind of compartment were within normal, at least on echo. And when these patients get older, these are some patients you may want to, you don't want to lose track, because you see this PDA is left to right, but the velocity are not so high. So you always want to, make sure that underlying to this PDA, the PVR are not still increased, because what from this duct is that the PVR are lower than the SVR, but there might be a situation where downstream the PVR are still supranormal, and once the duct will close, there might be some issue with this baby. So it's basically a patient you don't want to lose track of. Then you have a situation where you have these suprasystemic RV, and you're going to do exactly the same exercise to try to understand, this septum is bowing towards the left ventricle in systole. So, it tells you that the RV systolic pressure might be higher than the LV systolic pressure. And, then it's for, the comprehensive evaluation to understand, well, is it because my RV has abnormal pressure? Is it that my LV has too low pressures? So think of an LV that is being exposed to very low systemic vascular resistance and the duct is closed. So fulminant E. coli sepsis, for example, with a flash refill. You could have a situation where this patient has transposition of great arteries, right? And obviously the RV is systemic. So when you look just at a one-cut image, it doesn't tell you the whole story. It's for you to be able to then decipher what's happening distal to that compartment. And then you have the tricky part where you have these very round septum in systole. So that's the LV being very round and the LV being nicely crescenting. And I can tell you this patient had a closed ductus arteriosus and TR that was 2/3 systemic. So telling us that the RV pressure are a bit increased and the PA pressure a bit increased, but because the LV pressure was much higher than the RV pressure, well, you still have this very nice circular LV at the peak of systole. So always consider that if you have LV hypertension, you may still have, concern on your RV side. You can have PVR that, are still infrasystemic, but still abnormal. And so then you have to keep following these patients, or especially if you have other metrics of concern. So this is an example, again, of a huge left to right PDA that will, equalize pressure on both ends. I would not be surprised that this patient had a flat septum on the echo, because by definition, the PA pressures are going to be isosystemic, but it's the relationship of the directionality that tells you what's happening on the PVR versus SVR. And here we know that the PVR are much lower than the SVR throughout the cardiac cycle. These are PDAs that are bidirectional. They're quite different. One of them is quite large. So you can see the velocities across it are very low. And that tells you that, of course, you have isosystemic PA pressure, but in systole, you have slightly higher PVR than SVR. And then for the rest of the cardiac cycle, your PVR are lower than your SVR. And in that context, your RV might be having very nice contractility because it's able to offload, if there's downstream high PVR, it's able to offload into the systemic compartment. Compared to this patient, this is not a preemie, this is a CDH who had a closing ductus, and you can see it's bidirectional. And at this point, because it's much smaller, it's restricting that pressure equalization phenomenon. And you can see that you have 30 millimeters mercury in systole above the aortic pressure, because you're right to left here in early systole after the QRS. And so while the duct is not a great window to use the Bernoulli equation, because it doesn't satisfy all of its assumption, it gives us a sense that here both the pressure and the resistance are higher in the pulmonary compartment during early systole compared to the aorta. And then you have the situation where your duct is completely right to left. Here it's restrictive in the sense that it's small, it's not able to pressure transmit. And you can see that the gradient is of high velocity in systole. And so this patient may have very high PVR or very low SVR. This could be, a coarctation with closing duct. This could be severe pulmonary hypertension secondary to high PVR. This could be a situation where you have basically aortic stenosis, for example. So it's then for the clinician to go over all these diagnoses and make sure with their cardiology service that they've ruled out some of the congenital heart defects that also could be associated with this duct phenotype. This was a premature infant who presented with a severe quote-unquote PPHN picture, and you can see there's a right to left shunting at the at the ductal level. And because the duct is wide open, this patient will have isosystemic pressures, but the PVR are much higher than the SVR. And you can see that this duct is completely right to left. So this patient actually had just a flat septum, but it's very clear that a huge magnitude of volume is being shunted from the PA to the aorta. And so the QPQS will by definition be very low or much lower than 1, because a lot of the component of the RV output is just being rerouted into the aorta. And this patient had obviously pre and post ductal SAT differences. And so if we go in the postnatal life of some of these babies, the atrial directionality will inform you on the underlying compliance of these ventricles. So it's very common to see in preterm infants these left to right PFO or interatrial shunt, or these bidirectional interatrial shunt at the beginning of life as these patients are transitioning. You will not see strict right to left shunting in normal physiology or normal, transition. So that will be a very big red flag if you see that in your premature newborn or even term newborn. And then when you do have bidirectional flow, the magnitude of the right to left component will inform you on how much you're going to be sending the oxygenated blood into the left atrium and eventually pre-ductal states. So I'm not going to go over this list, but if you see a strict right to left shunt at your atrial level, what I always tell my training is that the first thing you need to rule out is obviously a total anomalous pulmonary venous return, because all your pulmonary blood flow is coming back to the RA and there's nothing coming back to the LA. So it's an obligatory right to left shunting. So that's the first thing that needs to be ruled out. And then eventually you go through your other diagnosis. I've put, quite a number of them here, and there's probably more. But things like, of course, PPHN could be causing a component of this, where you have poor RV compliance and RV failure. So then your RA pressure starts rising. But you do have other congenital heart defect you need to rule out, like tricuspid atresia, pulmonary atresia intact septum, critical PS, double chambered RV, severe Epstein, and some of these other causes. So, of course, the minute you have the oxygenated blood entering your systemic circulation, it will impact saturation. But having a right to left shunt at the PDA level or PFO level doesn't tell you necessarily that there's high PVR or abnormally high PVR, because it's always a relationship that between PVR and SVR. So it's to keep that in mind. And then the other thing is the magnitude of that shunting that will eventually influence your systemic compartments in terms of the desaturation level. So of course, if you have no duct, you're not going to have a pre and post ductal SAT differences. If you don't have an atrial shunt, you're not going to have pre-ductal desaturation. just because the RE pressure is high. What's going to happen is that your kid is going to go into low cardiac output and eventually become very gray, and your liver is going to start to balloon, but the baby might not be desaturated. So, of course, it's to keep that in mind. So pre and post ductal sat differences doesn't tell you always that this kid is in a high PVR situation solely. It could be because there's severe LV dysfunction as well. So if you have right to left shunting at this level, will make you desaturated at a preductal level. The reasons you could be preductally desaturated, it's either because you have VQ mismatch and a lot of hypoxic blood comes back to your LA. It could be because you have right to left shunting at the atrial level via a PFO, for example, or an ASD. It could be because you have right to left ventricular shunt. Or it could be because your duct is systemic, so it's providing blood flow to your aorta, and retrograde fills your preductal aorta because there's no LV output. So keep in mind these different mechanisms when you're seeing your patient preductally desaturated. If you have postductal desaturation and your DSAT is different than your postductal SAT is different than your preductal SAT, it means your PDA is sending blood flow from your PA to your aorta. And that could be, either that you have such high PVR that you're shunting right to left here, or it could be because, for example, your LV has no output. So keep in mind that sometimes this PDA might create a systemic circulation, and your PD is dependent on this systemic circulation. And so giving INO or pulmonary vasodilator might not be the best idea in that. So now we'll try to spend the next 10 minutes to summarize this in phenotypes. So there's a classic acute PH where you have very high PVR, still a wide duct that's open. Because of the high PVR, a lot of blood flow gets shunted into your postductal aorta. Because of the low QPQS, your LA is underfilled, and so the LV preload is very much dependent on the right to left shunting at the atrial level. Think of the 2-3 RBCs coming back to the LA, and this RA, getting a lot of the blood flow coming back from the systemic compartment, just because you're sending a lot of blood flow from the from the PA to the aorta. And so these patients will have pre and post ductal SAT differences because of the magnitude of shunt at this level, and they will be preductally desaturated because a lot of blue blood enters the LA. So clinically, they will look blue preductally, and they will look even more blue postductally. They'll look like this on echo, where you have big PDA shunting right to left, and here we have a bidirectional, but mostly right to left subcostal view of the right to left shunt at the atrial level. And so I've put on the NeoCardiolab website a case in August 2025, which is exactly a 24-week baby who was born in the context of chorio and was found to have a positive bacterial culture, very early onset. And you can see that this patient, although had quote unquote normal blood pressure in the systemic compartment, had a fully right to left PDA that it was wide open, low velocity. Here you see the Doppler, had a flat septum because by definition, the pressure are isosystemic, but the PVR are suprasystemic. You can see here that the RV looks pretty vigorous, but there's a component of TR, so it's very easy for the RV to pump backward because the RA has very low pressure. But because this duct is wide open, there's probably also a component of offloading of this RV, which is able to maintain its function. But you can see that this is at the cost of significant right to left shunting at the atrial level. And here I put the Doppler where you can see that it's near completely right to left. So this baby was very hypoxic from a preductal level, as well as hypoxic from a postductal level, and was treated as such, and treating, the component of high PVR, of course, by also taking into account the infection and all of these other factors. Then you have situations where your PD is near closing or very restrictive. So think about these preemies getting, a bit of a later onset sepsis or stressors that may impact their pulmonary vasculature, and the duct is almost closed or near closed. Although we know that sepsis will often reopen this duct, but there are certain situations where it doesn't. And then these patients may just don't have pre and post ductal SAD differences because the magnitude of the right to left shunting is just so minimal. And at that point, the RV might be facing extremely high afterload. And so the RV may start failing. And so these are situations like this. This was a 32-week baby who ended up with a later onset infection, if I remember well. And you can see this RV that's dilated with significant TR. At the time of this echo, this baby had around 50 to 55 systolic pressure in the aorta. And you can see that we're quite suprasystemic in terms of pressure read into the RV, and there was no pulmonary valve stenosis. You can see bowing of this ventricular septum in systole. This patient actually had still a small PDA, and you can see that, you know, the right to left component is definitely suprasystemic, and so had more, you know, a phenotype of high PVR with a component of RV dysfunction and RV dilation. And so in some of these patients, you're going to address the PVR, you're going to address the RV anotropy, and sometimes if they need rescue, you might even consider giving medication like PGE to reopen this duct, although this is very rare in preemie that you have to do that because there's always the concern of reversing the shunt in these patients. And then you have a situation where the RV is so bad that you get, again, this concept of functional pulmonary valve atresia. What does that mean is that the pulmonary valve doesn't open. You got just no RV output. Everything is going backward. And thankfully, many of these patients have sufficient foraminal valley to be shunting their RA preload into the LA to maintain LE preload and LV preload. And eventually it's the LV that provides blood flow to the pulmonary vasculature via a duct. And you can imagine if this duct is closing that this situation can become quite precarious. And so these babies are going to be very blue. There's not going to be any pre and post ductal SAD differences. And it's really by, you know, getting more echo-based information that you'll be able to kind of decipher this phenotype. So this is one example of a baby who was born with very severe RV hypertrophy. The RV was completely crowded, and we were not able to, you know, support RV output because there was just no RV filling. Everything was going back via TR, tricuspid regurgitation into the RA. This was a preemie 25-weeker. You can see the PDA here that is left to right, and you can see the PFO that is completely right to left. And this baby was on 100% oxygen, unable to be oxygenated with saturation in the 60s. And you can see here a Doppler in the RV output that is very low. So that's just the VTI, but the RV output was calculated in 30 cc per kilo per minute, so extremely low. And so what we did here is that we opened the duct, and this is a view to show that now the RV, which is hypertrophied, is nicely preloaded. And the reason that it's nicely preloaded is that you increase your LE pulmonary venous return, and you limit the magnitude of this right to left shunting at the atrial level. And immediately this patient started saturating appropriately, and we were able to nicely deventilate and reduce the amount of oxygenation in this patient. Whether or not we changed anything, but I can tell you this patient survived and went home at around 38 weeks corrected age. We recently had a case, this is the case of September 2025, where this was a fetus exposed to a ruptured membrane at 18 weeks and anhydramnios. And you can see here the pulmonary valve that is not opening. There's, you know, continuous pulmonary insufficiency actually throughout the cardiac cycle. When we did a Doppler in the RVOT, there was barely any output, if any. Actually, I don't think there's any output. The PDA was wide open at the time and left to right. So we know this is a pulmonary, a ductal dependent pulmonary circulation. And the TR is massive with completely right to left shunting at the atrial level. So this baby was very, very hypoxic. What did we do for this baby is we didn't start PG because the duct was wide open, but we started dobutamine to support the RV function. We did start INO to decrease RV afterload and promote forward flow, which was weaned 24 hours later. And eventually this patient completely recovered from this phenotype. There's obviously always the rare situation that the duct could be closed early or even prenatally. And so these patients won't have pre and post ductal SAD differences, but they'll appear with, you know, very struggling right ventricles if the PVRs are very high, and they won't have pre and post ductal SAD differences, but they may have very hypoxic situation because there's a huge right to left shunting at the atrial level. And so these patients have to be managed very, you know, differently, or at least using both inotropy to support the RV and medication to try to decrease the PVR. And this was a baby born around 34 weeks. And then you have the mimickers because of LV failure. So you can see severe LV failure here. At this point, the duct provides blood flow in the systemic circulation. You can see that, you have a full left to right PFO because the LV pressure starts rising in this baby. And so they will present with pre and post ductal SAT differences, but this is not a patient you may want to give pulmonary vasodilator because there's actually, high LV pressure. And what you want to do is maintain or make sure this duct continues to support the systemic circulation by the RV while you're trying to recover the LV from this phenotype. Recently, this is the case of March 2025. This was a 30-weeker with an asphyxiated context, and you can see the aortic valve that's barely opening, the LV that's barely moving, and a huge right to left duct with a completely left to right PFO. So that's exactly this phenotype. And this baby was desaturated everywhere. Why? And I put a still frame here, is because this duct was actually feeding retrograde this aorta. And so what you want to do here is really support inotropy and really avoid having a drop in your PVR, because at that point, your RV is systemic and providing blood flow to your systemic circulation. So I do have a few minutes left. I want to make sure that we go over management. I think when we think of acute pulmonary hypertension, we're immediately thinking of INO. We all know that the trials in preemies have not shown that INO makes any difference in terms of mortality or outcomes. But many of these trials were done to try to prevent BPD and not necessarily with the PPHN, quote unquote, phenotype or high PVR phenotype. And so, they were done in the context of hypoxic rest failure or even prophylactically. And even if it's in the context of HRF, HRF in a preterm can be respiratory, could be cardiovascular, could be cardiorespiratory, or could be something completely different like infectious, septic, or metabolic. And so it's for us as a community to be able to describe these phenotypes. What we've done at the Canadian level is that we don't forbid the use of INO in preterm, but we remind people that, of course, it needs to be given into the right context. And until we have better evidence, we still mention that INO being an agent that can promote, VQ matching and support the drop in PVR. If there is echo or strong suspicion that the diagnosis is high PVR, then INO can be something to consider. And this is especially true as a rescue modality in those with phenotypes of pulmonary hypoplasia. This comes from, very limited data. This is the PINO trial, which is a secondary analysis of the NINOS trial, where they, compared 6 INO babies to 6 placebo baby in these pulmonary hypoplasia phenotype and found that the mortality was much decreased in these 6 babies. But you can imagine how these cohorts are very, very tiny. We looked at the Canadian level and we saw a similar kind of trend or similar picture, but that's, again, retrospective and observational. So, with a lot of biases. And what we've seen is that, at least in the early acute pulmonary hypertension, if you have INO response versus non-INO response, you had, much decreased mortality. And so I think for me that this is the lesson, that if you have a baby that you do decide to expose your preemie to INO, then you should be very careful that if there's no response, the reason why there's no response, first of all, are you misclassifying your phenotype? And second of all, if there's no response, to consider weaning and changing your strategy in this baby. And this is just to bring about the fact that the Toronto group did look at an extreme preterm population and did find that, again, response was associated with strong survival when they have echo evidence of acute pulmonary hypertension or high PVR. And so I do think that there's at least contextual data showing that some of these babies do respond, but we do have to be extremely careful in these patients because you don't want to reverse the shunt and create a setup for pulmonary hemorrhage. I'll skip this slide. So how do I manage? I will typically look at these different phenotypes until I get better RCT evidence. And if I see that it's a problem with the pump, I'll support my pump with agents like dobutamine and epi. If I think it's a high PVR state, then I will consider optimizing my ventilation and my PVR status, and eventually work with other agents to try to, promote that pulmonary to systemic ratio. If I do have LV dysfunction, this is what I'm going to tackle. I'm going to think about my dobutamine or my epi to support this LV. And sometimes I'll maintain even my duct open in some of these patients, although that's very rare in preterm, I'm going to mention. And if it's the RV dysfunction that's a problem, then I do want to, decrease both my afterload of the RV and then work on the anotropy of the RV. So in all of these patients, please, beyond the cardiovascular management, make sure that you're providing comprehensive care. So ensure appropriate ventilation, oxygenation. I do titrate my oxygen, and once I see no response, I just stop increasing my oxygen, because if there's extrapulmonary right to left shunting, at some point, the effective oxygen may even be just toxic. I do sometimes consider a bit of sedation analgesia in some of these babies if I see there's a reactive component, and I always think about other things like hypogermia, seizures, hypoglycemia, and metabolic disturbances that could be contributive. And so if despite the optimization, I still have situation of high PVR and hypoxia, I do consider INO as my first line for decreasing the PVR, but I do wean if it's not working. And I do follow very closely these babies to make sure they don't reverse the shunt. And the minute I start having no pre and post ductal sat differences, I look into to see, is my duct just closing, or is it that I reversed my shunt? And at that point, I try to wean the INO. If I have ventricular dysfunction, I work on inotropy. If I have a restrictive duct and compromised output, I consider PGE. Again, that's very rare in preterm. And in situation where I do have worsening RV function and preserved LV function, I would consider sometimes vasopressin or norepi in some of these patients, and always think that these babies are immature and they may have some consideration of relative adrenal suppression. I put this for your reference. You'll have my slides. I do prefer the one from Dr. Satyan, which has, whatever is inotropic will be of a bigger heart, whatever is going to cause pulmonary vasodilation or vasoconstriction, and the same thing on the systemic compartment. And that, once I decipher what's my phenotype, I actually look at these boxes and decide what will be the best agent. But the most important thing is to avoid the soup of polypharmacology. And if you have an agent that's just not working, always go back to your drawing board and make sure that you consider changing strategies. So in conclusion, preterm infants are at very high risk of some of these disturbed transition to extrauterine life. Not all hypoxic rest failure is acute pulmonary hypertension, and I think terminology and phenotype is very important to understand what we mean by acute pulmonary hypertension. And once you have your echo, either by cardiology or neonatology, you can use that to enhance both your diagnostic and tailor your therapy and eventually follow your patients. I do think we need more studies, more trials, and trying to better isolate these phenotypes and use these phenotypes to be kind of studied for the best pharmacological and comprehensive approaches in these patients. So thank you. I'm open for any comments, questions, or insults. And sorry if I ran a bit late on this talk.
Thank you very much, Gab. That's a fantastic talk as usual, and really lots of food, for thought, and hopefully we'll have a discussion. I'm conscious it's 3 o'clock, but we'll just give 10 minutes for questions and answers. That's okay with you, Liam?
Yes, good idea, Mahmoud.
Yeah. So for those who don't know me, I'm Mahmoud Montasser. I'm one of the neonatal consultants in University Hospital Wishaw. Also the chair of NeoFOCUS-UK Special Interest Group. I have a pleasure of having Dr. Bikash with me today. He's a neonatologist in Medway. He's also the clinical lead there, and he's the treasurer of NeoFOCUS as well. So Gab, I just wanted to start with this question about the cardiopulmonary interaction. Obviously, as you already beautifully alluded in your talk, pulmonary hypertension is not one size fits all, and we shouldn't be treating every case with a single regimented approach because there are so many phenotypes. What are your thoughts about implementing lung ultrasound and echo in understanding what's happening? Quite a few times I come across babies with like preterm babies with oxygen like 35% had already initial dose of surfactant. And the first thing that comes to the bedside clinician to give another dose of surfactant without even trying to figure out what's happening there. And quite often what happens after that is that you start not getting much response, then you give a third dose of surfactant, and guess what happened next? It's just a case of pulmonary hemorrhage. So have you thought about having this consistent approach of using lung ultrasound along with echo to understand first what is happening with the lung? Is that RDS? Is it under-recruited? Is it over distended? And to try to understand more about the response, because sometimes it's over-ventilated and there is no enough venous return to the heart as well. So quite a lot of integration, I think.
Thank you so much, Mahmoud, for this question. I think you beautifully summarized how amazing neonatology is, in the sense that, you know, I think when we're at the bedside, every baby is so different, first of all, and we have to keep in mind that's the beauty of what we do, right? The beauty of trying to figure out, well, what's happening with my patient, and trying to work with recipes. I think we're in an era that we just cannot work always with recipes. It's good to have guidelines and to standardize the care. We're a unit that really believes in protocols and trying to align ourselves into making sure we have consistency of the treatment that we provide to our babies, because of course that improves a lot the outcomes. But I think that once the baby is outside of the box and not following the typical trajectory of what you would expect to happen at the bedside, then it's important to go back to the drawing board and trying to understand whatever the tools you have, and really try to spend some time. And we all have busy NICUs where, you know, we come on call and then there's like, you know, all these deliveries and transport and consult. But when you do have these vulnerable babies that are in these kind of early stages of critical transition periods, I think just reflex reaction can also be a bit of a danger to some of these patients. And going back to what you said of at the bedside and trying to understand, well, is that really the good management to do? And that's true also for when we introduce treatments and we see there's no good response, or the baby continue to kind of trickle down, right? So in our unit, at least I can speak for just my own unit and experience, we have a very protocolized approach to our tiny preemies. But when they get out of their usual response expectations, we do try to go back to bedside and use whatever tools we have to better understand, well, what's happening at the respiratory level, what's happening at the cardiac level, what's happening in the overall aspects of my patient, you know, not just the heart and the lung. Is my baby seizing, for example? Is my baby hypoglycemic? Is my calcium abnormal? Am I controlling the infection correctly? Is the patient bleeding somewhere? So there's so many things that could happen to some of these very vulnerable babies in their early ages, that just saying, oh, you know what, I'm just going to give a second surfactant, and maybe that's the answer. Maybe, you know, the second surfactant is the answer, but sometimes it's not. And so I think when you're getting to that level of deciding, I'm going to be giving this therapy, or I'm going to increase my ventilatory support, or I'm going to try to start an inotrope, or I'm going to start ino, you need to go back to the drawing board, because these therapies are not things that we do every day for all our preterms. I can tell you that in our unit, it's not common that we do second surfactant. So we really try to make sure, okay, is this really an RDS that's been badly controlled? Is it because I really have a situation of, you know, atelectasis or poor pulmonary recruitment? Is it because my tube is too far, not too far? So I think if your unit has the ability to practice lung ultrasound to answer some of these questions very early on before intervening, then definitely that's part of your array of tools. I can tell you that in our unit, we're only about 3 neonatologists, I believe, that actually can do, you know, very routine lung ultrasounds, although we're trying to improve the access to this tool. So sometimes in some of unit, it might be X-ray until you're able to actually do these spot evaluations that are coming with less radiation, that you feel comfortable acting on them. I feel very comfortable, obviously, by TNE, and my colleagues will often call us or the cardiology team if it's in the middle of the night and we're not available to try to get some of these information when things are getting out of the usual. But I do hope people will be sensitized to the fact that whenever things are not following the trajectory that you expect, you should go back to your drawing board and do, all of, and it's fine to even do a drawing. Okay, this is what's happening in my lungs, this is what's happening in my heart. Sometimes at 3 a.m., I also do that. I'm like, okay, well, what's happening with my hemoglobin and why my baby is blue? Like, how come initially he was like, and what was the trajectory too of the story of that? So we go back as a team with the nurse. Locally, we also have respiratory therapists, and we try to understand, okay, are we going to give the second surfactant? And what's happening on my TNE, what's happening at the bed, on the gases, what's happening. So it's a story of putting everything together. I don't think there's a single test that gives you always the answer. I think it's a combination of trying to better understand your patient. And of course, that's also in the balance to make sure you're not overdoing things, because these babies require a lot of, gentle manipulation, but gentle manipulation doesn't mean neglect. And so it's important to kind of cohort what you're going to be doing for these babies, not overdo it, but at least be thoughtful about these interventions, which have side effects. Starting INO on a preterm, if you have a left to right PDA and steel in your aorta, well, definitely you're going to worsen I think you're going to worsen your situation. And if you have a patient that has a severe left ventricular dysfunction and you start cranking up vasopressin because, you think this baby is hypotensive, well, maybe that's not the best also agent to start in that baby. So I think hopefully that's kind of the message I'm translating through my presentation. And I'm very open to disagreement and insults and comments, because I think that's how we advance neonatology. But that would be my answer. But I think if you have access to these extra tools and you're able to do it in a focused manner, and that's NeoFOCUS presentation, I think that will really help guide some of these treatment strategies in your patients and follow them as well once you introduce some of these treatments.
No, thank you, Gabs. Mahmoud, if you don't mind, I pitch in. I had a lot of questions, but I will hold it and I will text you personally to find those answers. But there are 4 questions from the audience, and it won't be fair. So I've combined all the 4 questions in one question to ask you. I've tried to do that. So given the dynamic physiology of this acute pulmonary hypertension in the first few days of life, how would you recommend repeating follow-up scans to guide management? This was asked by Gaurav. And in that context, when faced with preterm infants with acute PH and RV dysfunction, what is your position in using milrinone? And so these are 2 questions which are combining most of the questions together.
Oh, wow. That's very good question. We know these babies are very dynamic in their both response, but also transition in general. And that's true not just for the pulmonary vascular compartment, but also the systemic vascular compartment, although we've seen some changes with the introduction of more consistent delayed cord clamping, I believe. I would say that the minute you're starting treatments, that's the patient for me that is a time bomb. In the sense, whatever treatment you're going to start in terms of cardiovascular management, if you're going to start a cardiovascular drug, like either an infusion of a medication or inhaled drug like inhaled nitric oxide, although in some areas of the world, it's going to be inhaled prostacyclins, rarer and rarer, but still in some places, that's what they do. The minute you're going to start cardiovascular medication, I believe you should have certain checkpoints, both clinically and using some of these other tools that we have access to, like echo. So I can tell you that for me, if I decide, for example, start INO at the bedside, I want to be called, or I want someone to call some of my colleagues that are able to get echo-based information the minute the pre and post-ductal sat difference will start being the same, for example. Sometimes you have an immediate response, and you'll see like, oh, the baby is satting like 95, 95, and then you start weaning your oxygen, right? Because if you lose this pre and post-ductal sat difference, it tells you that the shunting directionality or the volume through your duct going right to left is kind of reversing. And what I'm concerned then is, are you stealing? Are you kind of dropping your PVR so quickly that you're just going to flood your lungs? And so in these patients, I'll be much more, at ease of going back earlier rather than later. So I'll give you just practical example. If I see a baby that we're introducing INO and they're preemie, it's very frequent. I'll go a few hours later, check clinically how they're doing, discuss with the team, and even consider either repeating my TNE or do a challenge of weaning the INO. It's very rare in our unit that you're gonna see babies, especially preterm, that if they're starting on INO, that they'll stay on INO more than 24 hours. We're actually very aggressive at trying to wean. Sometimes I'll just say empirically, your kid is starting 95, was on 100% oxygen. You're now down to 30% and you have minimal setting on your vent. Just wean, just try to wean and let's see what happens, and we'll repeat the TNE tomorrow. It always depends on what I've seen also on the first check. If on the first check I've seen like severe RV dysfunction, that might be some baby that I might want to do a spot check to see how the RV is doing. And I wish I had like this is the time-based protocol that we use. We do echoes every 3 hours. We don't do that. We actually try to tailor with the baby, because if I come at the bedside and the nurse tells me, you're not touching this baby, I'm not touching this baby. So I would say it's dynamic, and discussion with your team. It's also seeing the response, the clinical response. And as you titrate these medication, how is your baby behaving? But of course, my message is, as soon as you can get rid of these poisons, get rid of these poisons, because it's basically that's what we're doing. We're trying to benefit from their quote unquote side effects to improve the phenotypes. But at the end of the day, they have also side effects that can be quite detrimental. So it's important to keep that in mind. Now, what about milrinone? Milrinone is a great medication. It's a medication that, of course, presumably will decrease PVR. It will also act on your SVR. It is renally excreted. To context, so when I choose medication, I always go with what are the things that I don't want to have? What are the medications I don't want to start? And then I narrow it down to what's the medication that I think will be the best based on side effect and the profiles. I think milrinone, what I always look is, okay, will I start it in a kid who's not peeing? I will not, because it's renally excreted, number one. So if I see my patient is like this, that's not the drug I want to start at that moment in time. Might be something I consider later, depending on the evolution of my patient. Is my patient hypotensive, at least on whatever number scheme that I'm using? The kid who has, I think, you have a baby with 18 of systolic blood pressure in the aorta, it's probably not the great drug to start, because it's still gonna, drop more your PVR, might not be the best solution. That's number two. Number three, personally in preemies, I'm always a bit careful, because we already don't have much data in term infants. We even have less in preemies. It's not a no, never, I will never use in preterm infants. It's just, let's be cognizant that these patients are very immature, and whatever is happening at the cellular level, if you've seen a cell of muscle, you realize that they have like these reticulum, sarcoplasmic reticulum that are surrounding, and milrinone will act by binding on some of these receptors, increasing intracellular calcium. But these patients are, of course, very sensitive to calcium, but the whole intracellular mechanisms are very different than what you would expect in like an adult myocardial cell. So you have to be cognizant of that. And then the last thing that I always consider is, how acutely do I want an effect? If you want an effect now, milrinone will not give you that effect now. It's going to act with a bit of time. Sometimes you have like 6, 12 hours. So the two drugs that I keep in mind when I think, okay, well, I want to have an effect more on the long term are steroids, because hydrocortisone will take time to act intracellularly, and milrinone, which will take time. So if you need an effect now, I don't think milrinone will kind of kick in terms of inotropy immediately, right? So you need something else that, if your RV is completely a potato, you probably want to consider more something like dobutamine or epi, depending on your phenotype, than milrinone. But in the patient with high PVR, PPHN phenotypes, RV dysfunction, you've rescued the initial phenotype, but you keep on going back to see your patient and the RV always looks very bad, or you have poor RV relaxation properties, it's something you may want to consider. I'll give you an example. The baby with prenatal ductal closure, who presents very early on with this high pulmonary hypertension and RV hypertrophy, that's maybe a patient you want to consider, like improving relaxation of your right ventricle and introducing low dose milrinone. But you always have to be careful. Like, we don't use boluses in our unit because we're worried to have like hypotension based on this. So hopefully I answered that question, but I think it's a complicated one.
Yeah. No, thank you. It is, I think so. It is very clear, and you have answered it very, very well. Over to you, Mahmoud.
Yeah, thank you very much, Vikash. Thanks, Gab. Thanks, Liam. That was a fantastic session. Appreciate your time. Appreciate the audience questions. Apologies if we haven't managed to answer any question, but probably we can email you, Gab, if that's okay. Do you have any questions?
Can send them to me, and I'll try to respond to them like individually for all of them.
Perfect.
So if you have the emails of people, that would be great. If not, my email, I can put them in the chat, and then people can email me if they have any other question.
Amazing.
I don't know if this will, it's my first name dot last name @mcgill.ca. So now everyone has it. It's going to be on the YouTube.
Yes, exactly. So thank you so much. Appreciate your time. And over to you, Liam, for closing the session.
Thanks very much. That was an amazing talk. And Gabriel, do you mind if we put your slides, I just can see you sharing your slides on Google Docs. Would it be okay if we shared that on the
absolutely
WhatsApp group as well? Because I think that'd be fantastic. And I'll share that on the WhatsApp group. But just to say thank you for a fantastic hour and 20 minutes. That was brilliant, and just to again, for giving us your time, that's really, really appreciated. Thank you guys also for joining us today. If you could please fill in the survey at the end, and there'll be an attendance certificate there. We've got the next session in the next couple of weeks, but once again, thank you, Dr. Altit, for your time. That was an amazing talk, and thank you guys, and we'll see you in 2 weeks' time.
Thank you so much for having me. It was nice to see everyone.
Thank you.
Thank you. Bye-bye.
Bye.
Thank you for watching. If you enjoyed this, please check out the other webinars on our channel.